we're wanting to invite now questions from our audience in all 3 locations.
Yeah, I learned. I'm going to take some of the. I took a lot of points because I have teenagers too. But my question was on resiliency and the role of multi-generational setting in resiliency. Because we have a lot of patients who have family members that come from different parts of the world to support them during their pregnant time and postpartum time. There is conflict, but there is conflict resolution too. But it just came to my mind that the parenting model that we have in the first world countries versus the third world countries. Do you have any comment on that?
Oh, I love that question. That's a wonderful question. I think that so if richness in resources confers resiliency, for children to live in multi-generational settings, almost always confers resiliency because there's just more elasticity in the system, right? The likelihood of them experiencing neglect when a single parent has to work 2 jobs to provide food for the family goes down. The only risk that you worry about and you pay attention to is that a resource that is generally, not 100%, but just generally experienced as supportive by the primary parent? So every now and then, you'll have a parent who maybe is a survivor of abuse or has a highly contentious relationship with a parent who also lives in the home. They have what we nicely refer to as high expressed emotion in the home. And if that is stormy and disruptive, particularly if you have a child who has certain specific vulnerabilities, so if they have an anxious temperament, then you might confer a little additional risk. But I am always a fan of multi-generational homes, provided that there's certain escape places. There's places where people can also, the kids and the parents and the grandparents, also have some time and space to themselves to recharge. But that's a lovely question. I wish there was a way for us to have family communities that didn't feel quite so first world.
Thank you. So we have a question in Scotts Valley. So I don't know how our tech folks are going to get that question to us, but go for it.
Good morning. This is Ethan Robinson with STARS Therapy Services. I work with interventionists in the home supporting babies with disabilities. Dr. Dhami said, assess the maternal-infant bonding and assess it frequently. And I'd just like to hear, what should we be looking for? Is there a good tool to use, a screener? In my field, we're always looking kind of at the developmental milestones for the baby. What could I help my staff members who are in the home look for in terms of maternal-infant bonding?
So this is a great question. The tool that we use at El Camino, actually, let me take that back. There are many, many tools that are available. I was recently in communication with the University of South London because we're looking for similar tools that we're planning to use on our mother-baby unit, and they did send me several assessment scales that they use, which I'm happy to share with you if you send me an email after I get a consent from them. But the tool that we commonly use in moms is the global rating scale, and Professor Lynn Murray created it, and it's for infants 2 to 4 months, can be used up to 6 months. And it's, again, a play-based model in which we look at the mother playing with the baby, initially without a toy, and then mother doing 2 tasks. So it could be either a diaper change or feeding the baby. We record the intervention and then use it, rated using the global scale, which basically looks at the contact, the type of interaction, is it intrusive, the baby's response to the mother, the overall experience, the expression of emotion, the communication, verbal and nonverbal in the interaction. And for our moms program, we do it twice. So we do it in the beginning of the treatment, at the end of the treatment. And I actually watch the videotape with the moms, usually at the end, sometimes in the beginning, but usually at the end. And I compare both before and after. And it's really powerful in many, many ways. One is the patient sees how much their baby is attracted or looking at them. The second is they can see the difference in their parenting style and how much joy that brings to them. The baby has had a good interaction throughout, but it's really fascinating. And then the example that I was giving in the talk about this really aversive kind of attachment with a mom that's been psychotic and has been hospitalized. Um, that's also really important because what what I did with this patient was tell her, I didn't show her the video, and I made a deliberate choice because I, in my mind, thought that the way of showing the video would be it might be just too much, too harmful and traumatizing to her. But what I talked to her about was how she could engage with the baby more and different use of toys and sounds and it was really fascinating how the baby's attention shifted. So there are many scales, and I think this intervention is very powerful. There is a person, there's a physician, I don't think she's a physician, but there's a provider out of Netherlands. Her name is Karen Vendosum, and she's written extensively about it, and she came to train us at El Camino. I do have her book and some of her papers, so I can also forward those to you. Um, but it's great work, important work, and I think critical work.
So perhaps we'll get the scale from you and put that on with all the materials that we're collecting today. Do you have a comment too?
I just wanted to add to that, that if you don't have access to a scale in real time, sometimes screening to screen, so developing a sense of when to worry and then move on to a screening instrument can be helpful. Carlin Lyons-Ruth out of McLean Hospital has done a lot of beautiful work on attachment also, and often what you're looking for in general is a parent who attends to the infant and does a sort of catch and return with the infant. And the key is that the parent matches the infant's state, that they're not trying to intrude or control or push the infant into another place. If the infant's squalling and crying, then they show concern, right? They don't start squalling and crying. They don't mirror the infant's state, but they match the tone. They look concerned. They may make some soothing sounds. And does that interaction proceed in a way where the infant begins to go from up here and approaches some equilibrium, and the parent can kind of catch and return, where they gradually begin to reflect the infant's direction. So that's what you watch for, broadly speaking. And if it seems like they're either not attending, they're just detached or not connecting with the infant, then you may want to formally screen. Or if it seems like it's intrusive or aversive, or they respond in ways where the infant stays at a high pitch, it doesn't mean that it's causal. Sometimes you may have an infant who's really colicky, and it's really hard. You have to be able to catch and return at a high state of agitation for a long time. That's really stressful for new parents. I was marveling in your presentation, it was wonderful, by the way, at how the symptoms of postpartum depression and psychosis are different by degree from some of the symptoms of postpartum life for people where there's some disorganization, but it's not clearly pathological cognitive dysfunctional or disorganization. It's a stressful time, and if a baby is not soothable, that creates its own set of problems, and you want to offer supports that are different.
Got it. Thank you so much. So we have a question in the back. Wait, we have someone behind you. Sorry. And then you. Okay.
Hi, I work for behavioral health in the 0 to 5 services program, and we also serve postpartum depressed and anxious moms. And we've seen an uptick in kind of the psychotic presentation. I'm wondering, as Ohana is putting itself together, if there's a plan to have any perinatal beds.
Yes.
Yay!
Yes, we'd like to care for children. The plan is for us to offer family-centered care. Great. So while we evaluate children, we also evaluate families. We actively include parents in treatment planning, but also in treatment. And we like to treat children from basically 0 to 24.
Perfect. Next question here. It's good to hear. I think there's a lot of happiness with what you just said. So now our question, if you want to stand up.
I just want to know what, talking to the providers, what's their perception on treating women who have symptoms early on in their pregnancy? Mm-hmm. And, if it's proven, once you give them that tool early on, the first trimester, when you find out their pregnancy, if there's any improvements throughout and after.
So the first part of the question was perception of the providers, right? It varies from provider to provider. There are many OBs who are very comfortable in screening, assessing, and referring patients, and then there are some who are not. But as it was said earlier in the presentation, now there are new rules in California, and everybody who works with pregnant women is going to be screening patients. So I think it varies from provider to provider. Um, I Dr. Kathy Weissner from University of Chicago has a really wonderful a way to document how you screen and talk to patients and also to families and the risk. She said it was risk benefit, but the risk decision making process of recommending treatment interventions, including therapy or therapy plus medications. Um, so that's one way to approach this. And as we treat depression and pregnancy, all outcomes improve. These are outcomes that are, first of all, for the baby, but I also think the outcomes for mom's ability to access her own care during pregnancy. Um, and then mom's involvement with the baby. Like, I'll give you an example. We had a pregnant mom who was so stressed and suicidal. She had very little outside support, including the father of the baby, who was not very involved. When she came to us, she was depressed, not engaged, not taking care of herself. And interestingly, met criteria for severe depression. Um, she did not want to take medications, and although they were recommended, but we worked with her in terms of just connection with her unborn child, how she could sing to the baby, her own self-care, lots of cognitive behavior therapy, and then some interpersonal therapy with her, and also got her extended family to visit from China to help support her. And as she graduated from the program, she looked like a different person physically. She was interacting with her unborn child. She had a name for the child. She had a birth plan. Her OB was involved. She knew if her symptoms got worse to a certain degree, what she would do, who to call out for, and she was willing to do that. So you can do a lot of magical, great work if you intervene early.
Thank you. So we're getting close to time because we want to attend to resources. So if this can be a quick question, thank you.
Sure. I have, it's kind of a double one for each of them, if it's all right. Dr. Dharma, I was really concerned about the use. Is there a home visiting model after the treatment medically of the postpartum moms that you've had so that there's ongoing support for those moms over the years while the children are very small?
The answer to your question is I wish.
No.
We don't have it, but I have seen some home visiting models, not in the United States, but in Europe, and I've seen some in India, and I have seen their power, and also I've seen the power of prevention of some of these models, but unfortunately we don't have one where we are, but I wish we did. In fact, the videotaping intervention is actually a home-based intervention that's usually used in European countries and is so powerful. So yeah, I wish there was. And I just wanted to also add this comment about breastfeeding. So many of our moms are just, there's so much pressure to 100% exclusively breastfeed an infant and have a full-time job. And I just want to say that's just too much pressure on the moms. So that's another discussion that I often have with our patients, is to remove some of that stress and say, it's okay if you can't 100% breastfeed. You're not a bad parent. It's okay.
And then my question for Dr. Swick was about your presentation about what parents need to do to support a child and the major incidence of anxious children and anxiety in children.
Yeah.
Made me think about the fact that there's an awful lot of couples who don't work together in a family, and that creates a lot of anxiety for children. And so your parenting models being encouraging the mother and father to work together to learn these skills for their child, I think is critical. But a lot of times insurances do not pay for couples or family work, and so I was wondering how that might can be better.
Well, part of the answer to the question is advocacy, to advocate for treatments that work. And also, your advocacy can be economically driven. You can point out that there are low cost interventions. So I'm a child psychiatrist as well as an adult psychiatrist. But the work that I end up doing with a 16-year-old child who has anxiety, depression, self-injury, and substance use disorders is generally very expensive work. They often will need to see the psychiatrist, they need a therapist, sometimes they need to be in a partial hospital program if their self-injurious behaviors are really challenging. And I agree with you, often a great deal of the risk was conferred. They may have had some genetic vulnerability, and then the stress of divorce, and then the sustained stress of having her two primary, this is just a rhetorical example, her two primary advocates not be on the same page. And actually, the crevice between them could get wider and wider in ways that were centered on her, but not in adaptive ways. It would have been much more cost effective to offer, 2 years earlier, at the time of the divorce, offer her therapy and the parents very specific. And often it doesn't need to be framed as therapy. Often it's essentially mediation because they still have a joint project. So it's help find those parents to find a way to collaborate on their continuing joint project when they've decided to separate in most of the rest of their collaboration. And figuring out a frame that's going to work for them and having it all be very child-centered on what the child needs, get on the same page about both, being nurturing, attuned, and responsive, and usually the trouble comes with setting limits. And you end up with parents where one wants to be the good cop and one ends up being the bad cop, and suddenly you have a real hard time for that developing adolescent. So one, you advocate for reimbursement, you make an economic case for reimbursement, but also sometimes, and this is what we do in child psychiatry all the time, you find a way to make a little go a long way. And thinking about the resources that exist that serve as a bridge between those divorced parents. Sometimes there's a grandparent. Sometimes there's someone that still has some kind of civil connection with both parents. Or you pick the primary parent and another co-parent, and then you just aim to have the more estranged or separated parent sort of just a seed, sort of say, yes, I agree, with, not to actively disrupt both limit setting and plan making, if that makes any sense. So without access to real therapy, you still can make a plan that can often keep the child at the center and be pretty effective.